Hi everybody. So my name's Rob Cole. I'm an improvement manager for ECIST. That's the Emergency Care Improvement Support Team. And welcome to one of the latest ECIST podcasts. I'm absolutely delighted today to be joined by Natalie and James. And actually, I'm just going to go straight to Natalie and James and ask you to introduce yourselves. So I'll go to Natalie first, if I may.
Yes, hi, I'm Natalie Howson. I am the System Support and Delivery Manager for Yorkshire Ambulance Service, and I cover this South Yorkshire part of our patch.
Thank you, Natalie. And James, can I ask you to introduce yourself as well, please?
Hello, I'm James Goulding. I work in the Yorkshire Ambulance Service Emergency Operations Centre as the Clinical Response and Governance Manager.
Thank you both. And as again, just to reiterate, it's fabulous to have you join us today. So I'm going to go to James first. So James, can you talk us through the model or models you've been working on and just briefly explain the concept for us all?
Okay, so myself and Natalie, we've been working on what we call the YAS PUSH model. And what this model is all around is traditionally ambulance services, we would share work out with the wider system partners, but we would very much take a call in through our 999 or 111 services. We would wait a while until a clinician was ready to do a full assessment. And then following that assessment, we would then refer out. And we were looking at this and it seems quite a slow way of doing it. There was a big delays in the system, and to some extent we were duplicating a lot of work. So we had worked way back in 2021. We'd started a little bit of work with an accelerator site looking at what we called this push model. And what this was about was identifying incidents as they came into our service. And rather than waiting for a full clinical assessment, going, well, actually, this looks appropriate for a partner, and sending it straight to them where they would do the assessment and decide on the right outcome. The key bit for what I think we're talking about today is that was our starting point. But what we did in December of 2022 is we made a number of changes that really accelerated this model in Yorkshire and made it something a lot more than it had ever been before, really, rather than just those couple of accelerator sites, spreading out to a lot more services and moving us to just under nearly 3,000 attempted passes over just a few months in total to date.
Excellent, thanks, James. And Natalie, anything else just to add on that?
Yeah, so I think it wasn't just the push model that we changed. Certainly, James enabled that by restructuring a bit of the EAC, and I don't know if you wanted to go into that a little bit more, James, because I think that and the admin staff and bringing that around really did help sort of push that work out. So I don't know if you wanted to carry on that a little bit more.
Okay. So I suppose, yeah, you're right. There's other bits that enabled kind of where we got to, and I suppose we're talking very top level of the push, but there was other bits of work going on in the background. So we were exploring at the time a new concept, if you like. So again, your clinicians traditionally, we gave them an incident, they did an assessment, they got an outcome, and then we dealt with that. We were in quite a unique time, like most ambulance services, going into winter 2022, when the demand was completely overwhelming and we were really struggling to provide any sort of reasonable service to patients, especially those with low acuity conditions. They were waiting very long times. I don't think we were unique with that. And what we're exploring was what we call clinical navigators. And I think other services have similar things, but they might have slightly different names for it. And what these clinicians was rather than looking at individual incidents and triaging, was looking at the incidents and trying to almost stream them where they need to go. So what we were starting to do was what we now refer to as upstreaming these clinicians. So rather than in the past where we would take them through the triage and they would sit in the dispatch bay, so you think a very traditional model for an ambulance service is we have the incidents waiting and people look at the incidents that are waiting and do something with them. We turned it on its head to some extent. Well, why are we waiting for all that to happen? Let's put clinicians right in at the front, have a look at those incidents as they drop and go, well, actually, where does this need to go? Does it need to go to a dispatch bay for a vehicle? Does it need a clinical assessment? And that was where we dropped in this new idea of going, well, actually, maybe it does need a clinical outcome, but it doesn't need to be an answer. It doesn't look like it does. So could we give this straight to one of our partners? In conjunction with that, it came at a really good time for us because the wider system was trying to help. Everybody knew that the emergency system was really struggling, and there was some offer of help from the state going, what can we do to help? And we jumped on it, didn't we, Natalie, in all honesty? We went, well, what can we do quickly? One of the big problems for us was it takes time to ring another system. So we've got an instant, can we pass it to you? And we realised we could teach people very quickly to do this. So what we affectionately called the NavMins. One of our colleagues came up, it was our Navigator administrators. And what they started, they came from all different parts of the trust and the wider system to help us out. And they literally made that bits just easy. So your clinicians, rather than thinking, I've got this massive load of work I need to do, and I can see it there, but it's going to take me 10 minutes to refer. All that was gone. All of a sudden, they'd go, well, actually, this could go to that, pass it to the administrator, and they'd do it for us. It took that whole worry about it, and it let us rapidly send them. And we went from, where was it? We weren't even passing one every 2 days, roughly. And within maybe a few days of going into this model, we were pushing up to 10, 15, and we've continued to grow it. So we had a 30-fold increase in the amount of referrals we were making out. And that was without the full range.
Sorry, James. What would you make? I mean, that's absolutely brilliant. What would you pass per day now? So if you're at that 1 or 2, where are you now?
Somewhere around 30 a day at the moment.
And
we
still
go
growing.
A bit higher some days.
Yeah, absolutely. We're still growing.
New teams online. We've got new ideas. So it's a bear in mind, this all started a long time ago with UCRs.
Sure.
Then we brought in falls and bits. We're now starting to talk to GP collaboratives, to mental health crisis services, because our model's quite asynchronous, because it relies on the clinician spotting and going, this could go to a partner. That partner doesn't have to be a UCR. That partner could be anyone in the system.
And sorry, that's UCR being urgent community response.
Yeah, absolutely.
Yeah.
So obviously a big drive for UCR at the time, and they were there and they had this ability, and that was kind of where this started. But we've realised that not just them, there's other people in the system that can help us. And realistically, one of the key bits I suppose we found was trying to get people's heads around the fact that just because it's an ambulance job doesn't mean that's where it should be. And they were potentially going to get these incidents later, but following a clinical assessment on the phone. But these weren't normally ambulance kind of issues, so we may not be as confident as maybe a specialist would be. So we'd send an ambulance response out to kind of check maybe. They'd get that and then they'd refer it. So what we're doing now is taking out all that work that could be used for other patients and get them straight to the right place. Or as Natalie loves to say, no wrong door.
And I couldn't agree more. And again, just to summarise before I move on to another question, I mean, it sounds like that upstreaming of that conversation, that front loading of the model, that not waiting and passing straight away. And do you finally for me, do you digitally pass or do you telephone the job through?
Yeah,
so the moment
go on, you go for it.
So at the moment we pretty much pass on the phone. That is our next step now, is how we get away, because obviously the phone takes time. Bear in mind, we were doing this with, I suppose, no funding. It was a labour of love is another thing we keep liking to say. This is something we need to do quickly. But now we've proved this model to some extent. I think is now the next stage is how do we get away then from what was quick and dirty to some extent, a phone call, we could implement that. How do we get this into a much more, I don't know, robust long-term plan and some kind of digital solution? That'd be ideal for the future.
Natalie,
and I think
do you
as
want
well,
to come on that?
Sorry, I was going to say, I think as well what we managed to do with the NavMin was that we realised quite early on that the clinicians passing, phoning those services were really adding no value to it. And actually what we were doing was we were tying up a clinician when really we wanted them to be looking at these jobs and making it really, really a quick process. So by adding more and more sort of NavMins to that, we're able to free up the clinical navigators to navigate, to actually do that job, and then we can have those conversations. The NavMins can have those conversations with the services. So we're already sort of looking at that PDSA cycle of improving what manually we already have, but actually then looking to automate it or make it more automatic as well, or more electronic, I suppose.
And I think that's one of the fabulous things, isn't it? This PDSA cycle, we do something, you're evaluating it, you're looking for the next opportunity. And again, I think that's excellent. I mean, I was going to ask about why do this and why does it resonate and why is this an important piece of improvement? And I think you both beautifully and eloquently answered that about freeing up that clinical time, speeding up the process.
To add to that, I think really one of the main drivers was the lengths of time that we could see those patients waiting in that Cat 3 stack, was that it was because of demand. It was such a long time, and that we just felt that something else needed to support that, because what we were doing.
The category, sorry, Natalie, coming over you on that one, just to clarify, the category 3 being the slightly lower acuity, therefore they would continue to keep being effectively bumped down the queue. Is that fair to
Yeah,
say?
absolutely. And not just that lower acuity, but that the acuity of that 120 minutes response. So that
Okay.
2-hour response, which really aligns nicely to your UCR 2-hour response. So actually these are jobs that could quite easily code to UCR. They're expected in that time frame, and we are not making that time frame because we have so many Cat 1 and Cat 2 jobs, which are the emergency work. So it's really about being able to just think differently, and I think we just needed that over winter. So that demand really made that very apparent, that actually we had to change things, or we were just going to carry on in that way where the patients got just a significantly huge time that they were waiting for us to respond to them.
I think what I loved.
Sorry, James, go. Yeah.
The thing what I really loved is as paramedics, we often grumble that patients don't always access the service that we think they should, and forget that not everybody understands what service they need. And what this was for me was a really quick way of, rather than coming into our queue and waiting hours and hours for us to put them into the right service, if they came so they didn't really know where they needed to be, we could put them where they should be rapidly and get them that care they needed. This was a real quality piece for us. And we've got all of these different services in community, and we're all there to try and help out. That's what we're there to do, is provide the right care to patients. And what this was a way is helping us all work together quickly in a way that maybe we didn't do so well previously, if we're honest, as ambulance services, or we found more difficult to do. So I think it's been really positive.
I think that's really helpful, and I guess it almost sounds like there's a realignment, putting patients back in the most appropriate pathway as quick as we possibly can, and clearly, you're not the only ambulance service doing this, but you're one of the first doing it. And I think, again, good stuff just follows, doesn't it? Which is really, really good. Like anything though, what about your challenges or indeed the opportunities on this journey? Because I'm sure this isn't quite as easy as you may have made this out. So who wants to look at the challenges and opportunities? This sounds like, there's some improvement, but there might be a bit of redesign and here and a bit of transformation as well. So I don't know who wants to go first on that one.
So we talked about this, ready for this, because I think this is one of the key bits you need to understand. I suppose we talk about the things that are really great, and they were good, when we got there. But did we get there overnight? No, we didn't. There's no point pretending we didn't. Did we get it right on the first go? Absolutely not. I think the thing that was really interesting for me early on was how frustrated I could get at times with some bits. So we would start that discussion with a partner, and it would feel like we're on board, we're aligned, and then it'd go live, and then I'd be talking to Natalie going, I don't understand what's going wrong here, because these pushes aren't going anywhere. We're just getting rejection after rejection, and we'd go back and go, why is this not working? And what we learn, which I would share with any other provider, is there's a difference, I suppose, between engaging what I would think of as your top tier, like your leadership, and engaging with your grassroots. And I think and that's the bit we didn't quite get right at first. So let's imagine any one of the partners, we'd speak to them, and we'd all agree, and we'd have a really clear vision what we're trying to do, and we're going to work together. This is an excellent idea, let's go. But it didn't quite filter down so that the staff that were implementing it necessarily understood it as well. And then there would be nerves and worry, because they'd think, well, it's a 999 call, this isn't normally what we do. What we found really quickly, and what we now do, is bringing them into the OC and sending our staff out to them. And it sounds so simple now looking back on it, but the difference was, again, transformational. So early providers, we just brought them in for a day and went, have a look at what risk we're carrying at the moment, have a look at all these patients that are waiting. So there was obviously worry about them going, well, if we take this job on for half an hour while we do the triage, they're not getting their ambulance they could get, and someone could get hurt. And as soon as they started to see these big queues we were holding at the time and going, there is no chance of getting an ambulance, and actually not taking it is arguably riskier. And also showing them what happens if you take that call, and this was a big worry, we take that call, it looks all right for us, it looks like, but we all know patients change or they don't quite explain it, and that clinician gets on the phone and goes, actually, this patient's got, a barn door sepsis, so I've rung them up and they've actually got crushing chest pain now, they didn't tell, what do we do? And when they saw what actually happens is, rather than waiting for us to realise, and not all patients ring back, and we know that, don't we? Is
Sure.
some patients sit at home, I've rung an ambulance, I know they're busy, I can see it on the news, I'm not going to bother them and say it's getting worse, and I wish they would, but they don't all do it. By having that call quickly from the partners going, hang on, guys, we've noticed that something isn't right here. This patient isn't a category 3 at all. This patient is very poorly. We were showing that as well. So either they would get a job that was definitely theirs, and they'd be like, brilliant, we can sort this patient out, or if in the worst case scenario they got a patient who went, actually this is really poorly, it was safer at that time for them to do it because they could do it quicker than us. So it sounds so counterintuitive, but even in the worst case scenario, the patient still got a better outcome. It was a win for that patient, whichever way this went. Once they saw that, it was just completely different almost overnight, wasn't it? Once those staff saw that and could go back in theirs and go, this is why we're doing it, and this is the risk that's in the system for these patients. I don't know how to describe it. It was just a complete change overnight. And once we got our heads around that, I think me and Natalie, then we realised that this is part of that onboarding process. Is we've got to get the staff who are going to implement it on the day to see both sides, understand each other, and those relationships started getting built. And moving forward now, we try to, especially with new teams, give them a nominated point of contact, but not from a myself and Natalie level, at a very grassroots, one of a better term level, someone that does this day in, day out. They can have that kind of informal, well, you passed this job yesterday. Why did you pass that? I don't think that's quite right. Well, actually, this is why. And they go, got it now. And that seems to have helped this move forward. From my impression, I don't know how Natalie feels on this one.
Yeah, I think the PDSA cycle part of this is really important. I think we probably underestimated the risk appetite out there in the community. So actually, as paramedics, we are very used to emergency work. As nurses and advanced nurses out there in the community, they don't want that emergency work, but nor do we want to give them it. So it was really about them understanding of what our work is made up of, that we do have emergencies, but we also have a lot of urgent care work, and we also receive quite a lot of primary care work because it's very difficult to maneuver around our system. So I think it was about us realizing how they perceived risk, and being able to sort of engage with that. And sometimes it was just about turning it on, and so that they could see it coming through, that they weren't going to be inundated, because it was a massive concern. We're just going to be inundated, and really sort of being able to support them in that, and to talk through those jobs with that clinician to say, actually, this isn't something that we would take, or we haven't got capacity for that, and really understanding why they were declining jobs, why they weren't, which jobs they were accepting, so that we have that sort of monthly look over those jobs, and to know which way we're going. So, and one of the things that has been able to do is improve our acceptance rates considerably with those individual teams. So we take that is a little bit more work, a little, because you don't get anything for nothing, do you? So it's absolutely about putting that time in to make that, and then hopefully making that business as usual. And those PDSA cycles longer, and you say that we're not reviewing it every month, but actually we're looking at that 2 months. And so we've got teams on that have been on with us sort of from the start, which we don't have so much contact with now, because they know what they're doing, and that actually those are the teams that we're using to sort of start those conversations about electronic and digital work, and because they know how it works, and they're safe hands as well. So there is a little bit around them understanding that work and how it's processed, and that takes quite a while to embed. And I think we probably weren't realistic around how long that took to embed and then improve, because what we see is those numbers start very small, but they soon increase considerably, and that's around us as well, pushing to them. So every navigator still also needs to know that a new team is up and running, and they all have different referral windows. They all have quite slightly different referral criteria. So it's a lot for our navigators to keep in their heads or refer to. So it's trying to make it as simple as possible for them.
That's really helpful. And I mean, my next question I was going to ask, if you were a new trust and you wanted to go on this journey, what are the key points? But if I'm honest, I think you've covered the key points. And just to recap, it sounds like, I think, James, you referred grassroots, embedding it at the right level, maybe some of that more senior and exec buy-in as well, rebuking some of those absolute myths about you won't be overwhelmed. We don't want to pass you your barn door MI, your sepsis patient. This, it almost goes back to that realignment again. And I think, it's commendable what you've done. I think most trusts are doing something similar now. I think it's fair to say, there's push models and pull models and digital portals, but it's the broad realignment of patients. So I think,
do you know what we did that we haven't said though? So we talked about engaging, and probably the one piece of, I'd say to maybe the other trust to consider is we talked about how we engage with these teams. But as Natalie said, some of these teams were here from the very start.
sure,
we've got a really good relationship with them. What we did find with a few teams that rather than an ambulance service telling the UCR team how to do this and that they could reassure them and tell them how they worked it, we now had, after we got going, several UCR teams that knew how this worked on their side, and we could link those. It didn't always have to be us, and they kind of helped guide new team. It sounds so silly. Yeah, so we'd say, well, actually, you worry, but actually speak to one of our accelerator sites we've been doing this with for 2 years, and they could, and very quickly, again, we got that same bit. They'd go, well, all your worries, this is from a UCR perspective, how we've dealt, and they'd go, bang on, sorted. It didn't always have to be us with the solutions because our early sites had already solved them.
Doing the work for you.
You don't have to do it all yourself, I suppose, is the key. But when you're working together like we were, it's very easy to think, I've got to solve all of the problems. But actually, you've already done it, so why can't the other people involved help out as well? And there was a lot of joint work, and our accelerator sites have been ace for this, let's be honest. We wouldn't have ever got it to where we did without the early adopters.
Yeah,
it's really helpful. I mean, and again, and true integration. I think, and I like that. I love that buddying system. As in, don't hear it from us, hear it from one of your colleagues, one of your trusted professions. So, I guess drawing this towards a close, and question for both of you. You clearly want to move this forward, and maybe digitalization, and so magic wand moment. Natalie, I'm going to give you a magic wand. What do you want? What's your wish if you want to move this forward, and where do you want to go? And then James, over to you on that one.
So I think where I'm coming from, magic wand, would be around the partners and stakeholders really understanding what we're trying to do, that this work is more likely or not going to be coming to them anyway. It's not about us giving them ambulance job. It is us working as a system to improve that patient journey, and for them to really understand that actually we can cut down that time of that patient's journey, and that in itself will be a better quality, and with fewer resources utilized on it. So it is win-win. And I think understanding that and working as a system rather than, and YAS has a big system that it works with. We don't just work at place level or ICB level, we work at multiple ICB levels. So it is, I think, if I had a magic wand, it would be about that understanding, so because that engagement is the bit that takes the time. Actually doing, we can switch it on, James can switch it on in a day. That's not an issue. It's about really having that understanding there and having more teams, because that's how we get that work spread out. So the mental health teams we would like on board. There are so many mental health calls that come into 999 where a paramedic is not the right response for that mental health crisis, and we're seeing more and more of that, and so that is helpful. And the GP, the primary care work, being able to have partners that would take that work as well, so we can really focus on our emergency work. I think magic wand wise would be more system, not engagement, but actually delivery of that, being on board with us, and that not taking as much time, I suppose, because that's where that real sort of work is for me.
Brilliant, thanks, Natalie. And James, just before we close this one, your wand moment, where would you go?
I feel like I can't quite be as impressive as Natalie's answer, to be honest. She's put me in the shade now. I think for me, mine is much more operational. I think I look at the moment what we did. and I said it before, and it's not the greatest way to describe it, was a bit quick and dirty. We were in the environment, we had to deliver at pace. So we used phones because we could do it quickly. There's no getting around it. Do I think that's the right solution long term? Absolutely not. But what we've got at the minute is we haven't got an easy way to pass those incidents back and to between the different parts of the system. And I feel that we're probably using a lot of time on our side, even though it's using administration staff, but so are our partners as well. And there's got to be a better way digitally to be able to move these incidents around, maintaining when they came into, if you like, the system as a whole, because that's the big problem. We've got ITK links, things like that, and they go out. Sure. But obviously what you want to track is what point did it enter into the urgent and emergency care system. No matter where it goes around that system, it's still maintained. So if it comes back there, it hasn't lost its place in a queue, which sounds so silly, but actually it's really important that these patients aren't disadvantaged, because what this was all about was around quality. That's what me and Natalie started. We want to get the right outcome. And what I don't want to do is, by trying to do this, is where it doesn't quite go, because sometimes, we're taking a best clinical guess that we can do it. Every now and again, you'll get one that can't, and that's fine. But you don't want to have those patients being moved down the queue because of the way that system. So, getting me a magic wand is to give me the full digital solution to be able to move those incidents seamlessly around the different providers. But that's obviously going to be a challenge moving forward.
Honestly, it's absolutely fabulous, and I think I'm going to say here, maybe one of the magic ones is we probably need more Natalie and James, with your passion and your enthusiasm, because it's people that make these things happen. So, just a big shout out to what you're driving forward here. So I think it's going to be great to hear where you go in the future, and we'll do another one of these and see where you are in terms of that digitalization and where we are in terms of realigning patients to maybe the right services as quickly as we can. So thank you so much for your time today. Really appreciate it, and be great to hear what's happening in the future. So thank you both.